Good day to all of you. Here is our presentation and talk about IV solutions, IV fluids, and giving IV meds. I will do a lecture later on in the semester over the actual starting of an IV. One of the reasons we have IVs and we start IVs is to prevent or correct fluid electrolyte imbalances. And it also allows for direct access to the vascular system for administration of medications. During your reading and during this lecture, we will be referring to intracellular fluid and extracellular fluid. So here's the slide just to remind you of which is which. There are different types of solutions: isotonic, hypotonic, and hypertonic solutions. Isotonic solutions is where the intracellular fluid and the extracellular fluid have the same osmolality. Hypotonic moves fluid into the cell, so from extracellular into intracellular, so out of the vascular space. Hypertonic fluids move fluids out of the cell and into extracellular space. So that is moving fluids out from outside of the cell into circulation into the vascular system. There is a table on page 293 in your book. It's table 1617 that goes over the different types of fluids. I would make sure that you are pretty comfortable with the information on that in that chart. Also on page 294, there's another chart, not really a chart, a box, I guess you would call it, about teamwork and collaboration, and that would be something I would familiarize myself with also. Two of the main points I want to say about IV fluids is normal saline is the only IV fluid you can give while you're giving blood, when you're hanging blood. Your dextrose solutions, if it's less than 10%, can be given peripherally, but anything greater than 10% needs to be given through a central vein. Here's an example of a peripheral IV. I picked this picture once because I think it's funny that the IV is inserted the wrong direction. IVs are always inserted pointing towards the heart. We always start distally and move proximally for IV starts. Central lines, before we get to central lines, we have midlines, and those are inserted into the larger veins of an arm and extend about 8 inches up into that vein. So they're much more secure. They are less likely to have phlebitis. There's less risk of infections or infiltrations. We use this type of line when the patient is going to be on a medication that is a known vesicant, something that we know is detrimental to tissue if it infiltrates. It's also used for patients who are going to be on medication for longer than 5 days, but less than 28 days. It can also be used on your patients that just have poor vascular access. You know those 81-year-old weak and dizzy all over patients we all get who have no veins anywhere. You promised that they weren't born with them. Those patients, because this is such a larger vein, it ensures that we get good access for the entire admission that patient's in the hospital. This is the difference between a midline and a peripherally inserted central line. They're both inserted into the same veins. It can be the basilic, the cephalic, or the medial, and they're all right in that antecubital area. Some of the things with care for these is I would not be taking blood pressures on this arm. If it's a peripherally inserted IV in someone's hand, you can, of course, take blood pressures on that arm. But with a midline or a peripherally inserted PICC line, you don't want to, because the pressure of that cuff can cause damage to the inside lumen, inside wall of the vessel that the IV tubing cannula is in. Central lines come in non-tunneled and tunneled. Your non-tunneled are going to be your subclavian veins that are inserted straight into the subclavian vein, and then the tip goes into the superior vena cava. The tunnel, the incision is where it starts, is further away from the vessel, and then it's fed in through the vessel. The nice thing about tunnels is that once that incision site heals, they don't require daily dressing changes. Not daily, but they don't require dressing changes. I'm not going to spend much time teaching you how to do a central line dressing change because the hospital policies vary so from facility to facility, but your book does a really good job of the overview of the whys and the research behind dressing changes. The last kind of IV access, vascular access we have are implanted ports. These are even used for longer term because these can be kept in for years, depending on the need. Frequently, if they're going to be used that long, they recommend that the patient has it accessed at least annually and flushed to make sure that it is still working. The implanted ports, one of the things that you need to be aware of is that they come in different sizes and shapes, so you need to palpate to feel what you're dealing with, to feel where you can feel the septum, which is where the needle is inserted, feeling for any nodules or swelling around the site, just looking for infection. They also require special non-boring needles, and they're Huber needles frequently because they're at a different angle. You need to be aware of that these needles comes in different sizes and lengths. You want the tip of the needle inserted into the septum. You don't want it all the way touching the back wall of the device because you don't want to impede flow. You don't want it to where it's so loose because it's so tall and it's not secured in there that it can wiggle and rock back and forth because that can cause damage to the actual septum. So it's one of those things like we all like. We want just right in nursing. We're getting pretty Goldilocks. We want the flange of that Huber needle to pretty much be equal and flush with the patient's skin. When a Metaport is accessed, it has to have a dressing over it. And again, that varies by facility on whether it's an occlusive dressing or whether it's a gauze dressing. And depending on that, how often the dressing is changed. Generally, with dressing changes, the needle is removed and reaccessed because we want to change out the tubing and the access at the same time. Some IV complications. One is infiltration. This is the most common, and it is when the cannula has wiggled its way outside of the actual vein and we have fluid leaking into the tissue surrounding tissue. These can be painful when the patient complains of pain. This is usually the first thing we're going to look at. Extravasation is when it's a known desiccant that has leaked. It's had an infiltration that has caused tissue damage. The desiccants that we are mainly the ones that cause tissue damage are gentamicin, penicillin, vancomycin, dilantin, calcium, potassium. Any of your chemotherapy drugs, anything with a high osmolarity can be very damaging to tissues. Phlebitis and thrombophlebitis are the next complications. And these can be caused by, it can be a chemical issue with the vein just being irritated by the actual IV solution. Warm compresses can sometimes help these. And what's happening is that like higher rates of higher concentrations and a fast delivery rate of potassium will sometimes irritate and erode the layers inside the vein, and so that's what causes the localized phlebitis. It can be a mechanical irritation by the lumen, when it was inserted, damaged one side of the vein. It can also be due to a bacterial infection. Another thing that can happen with IVs is cellulitis, which is not just, it's an infection and inflammation of the connective tissue around the insertion site. It's usually caused by a contamination during insertion. The area will start to be red and swell and dissipate outward from there, will be warm to touch. The things we need to assess when we're assessing IV sites is there a patient complaining of pain? Does the skin feel warm, cool, or, as same as all the surrounding tissue? Any swelling? If the rate is getting decreased, if you keep having the pump tell you that there's an obstruction, downflow, not an upflow, but a downflow obstruction, all of those things are signs that that site needs to be investigated much more thoroughly. Here is just a horror story for you. A 19-year-old woman arrived in the ER department with flu-like symptoms, and she received promethazine. During the injection, she yelled out in pain and was tempted to pull out her IV. Afterward, she told the nurse that her arm was still in pain, and then she felt that something was wrong. The nurse assured the patient and left the room. The patient's arm and fingers became purple and blotchy, and this patient ended up being in the hospital for 30 days. Remember, she just came to the ER because she was sick to her stomach with the flu, during which time her fingers turned black and shriveled. Her thumb, index finger, and top of her middle finger had to be amputated. This lady was a professional guitar player, and she was awarded $2.4 million for past and future medical expenses and $5 million for pain and suffering after she endured 2 more amputations following an accidental arterial administration of Phenergan. So we just need to be very mindful. This is one of those horror stories that we all hear. Is this rare? Yes, but we certainly don't want to be the nurse that caused this kind of damage to a patient. So let's go over our medication routes. IV push. If the patient has a saline lock and is not receiving fluids, you flush with saline, you give your med, and then you flush with saline again. That follow-up flush is given at the same rate as for the medication. So whatever medication rate you looked up, that's how fast you give the flush. If the patient has IV fluid running and it's compatible with the medication that you're giving, you can let the IV fluid continue to run. You're going to access your port, and you can flush your medication at the same rate as you would if it was without fluids. If it's not compatible, if your IV fluid is not compatible with the medication you're giving, you can do 2 things. One is you can pause the pump, disconnect the tubing, flush, and give it just like you would be giving somebody a medication who didn't have fluid, where you would flush it with saline, give the med, and then flush again. If the patient, you can also bring the roller clamp down close to the port, clamp the tubing, flush the remainder of the tubing with your saline, give your medication, and then flush again with the remainder with some more saline. That's going to require a greater amount of flush, but certainly something that could be done. IV piggyback meds, we need to monitor the patient. The things I want you to remember, you can look at the mnemonic. These are the things you need to make sure. These are the safety things, the safety checks. We want to monitor that patient closely. A lot of times, one of the things we're giving IV piggyback is antibiotics, and antibiotics are known to cause some allergic reactions. So we want to watch for anaphylaxis or any other side effects. Hives, itching, shortness of breath, any of those. If a reaction occurs, the first thing we're going to do is stop the medication. Call the doctor and be prepared to administer whatever medications we need, Benadryl or epinephrine if it's an anaphylactic. Discontinue the infusion immediately if you notice any signs of infiltration, because we definitely don't want to get into some of those horror stories. And that is it, other than I want to make sure that you remember that you have to document all your interventions. And it's always a good idea to assess your IV site before you start and after you've given a medication. Looking forward to seeing you guys in lab.